Welcome to everybody. We have 500 participants on the line, as we did for the first session, which is fantastic. My name is Alex West. I'm a respiratory physician at Guy's and St Thomas's, which is also in London, just up the road from the Royal Brompton. We work very closely with King's, and in particular, working even closer as we go forward with the Royal Brompton Hospital. And we do a similar pattern of diagnosis, workup and treatment as the Royal Brompton. We have 4 fantastic speakers who are all experts in their fields. I will let them introduce themselves individually. What I will ask all 4 of our speakers is to, as per the first session, to try and keep this as clear as possible for you, to avoid the technical jargon, and if technical words are used, that they will immediately explain them afterwards to make it as clear as possible for the 502 people who are currently listening. In the chat, I would encourage you to put your questions there. With 500 of you, we'll try and get to them as many as we can, and I will ask our fellow speakers, once they've done their talk, to try and type some individual answers to you where relevant. I notice there's quite a lot of very personal, individualized questions, which you'll understand is difficult to answer, but we'll try and answer the themes that are there.
Alex, sorry. The questions are coming through in the Q&A, not in the chat.
I do apologise, Sue. I didn't mean that. You're quite right. It's the Q&A function at the bottom of your Zoom. I do apologise. Thank you for correcting me, Sue. And we'll try and answer them in the Q&A session if we possibly can. So, without further ado, I would like to introduce Dr. Elizabeth Renzoni from the Royal Brompton, who's going to kick us off regarding immunisation and interstitial lung diseases.
Thank you very much, Alex. It's great to be here for this patient day. And I've been asked to speak about immunosuppression for ILD. I'm Elizabeth Renzoni, one of the consultants in the ILD unit at the Brompton. So you'll probably have heard from the talks before that in interstitial lung disease, it's the interstitium that is mainly involved and thickened by inflammation and used often by scar tissue. And so if you compare the normal air sac schematic here, we know that the lungs are made up of millions of air sacs that have very thin walls within which are red blood cells that are traveling through, and the thinness of the walls means that the oxygen and carbon dioxide can travel very freely and quickly between the air within the air sac and the red blood cells. Whereas in the interstitial lung diseases, that space is thickened to varying degrees. We also know that there are many, many interstitial lung diseases, but to simplify, we can think of ILD, the most common ones, as idiopathic pulmonary fibrosis when we cannot identify a known cause and with a particular pattern. Those associated with autoimmune disease, including the connective tissue diseases. The most common associated with ILD are scleroderma, rheumatoid arthritis, myositis, and others. And then associated with a cause or exposure, including organic matter such as birds and mold, occupational ILD such as asbestosis, and drugs. And we're used to thinking of a separation between idiopathic pulmonary fibrosis, where inflammation is believed to play a lesser role, and there are unknown injuries that lead to a sort of self-perpetuating process of scarring in the lungs that worsens over time, and then non-IPF ILDs, including the connective tissue diseases, hypersensitivity pneumonitis, and others, where immune overactivity is believed to play at least a role in driving fibrosis. Now, this is a simplification, but just for general subdivisions. We use immunosuppressants to treat certain ILDs because we believe there is this overactivity of the immune system. The immune system normally protects us from outside injuries, including infections. But in the context of certain ILDs, that immune system is overactive and ends up attacking our own cells and tissues in the lungs. And this, we believe, is part of what causes progressive scarring. And therefore, we're using immunosuppressants as drugs that can dampen the response of the immune system, preventing or at least reducing the damage that could lead to progressive scarring. The most common immunosuppressive drugs include steroids, which you'll all have heard of and are often our first port of call. Oral immunosuppressants other than steroids include mycophenolate, azathioprine, methotrexate, and others. We can go for more intensive immunosuppression with IV treatments such as cyclophosphamide in selected cases. And then there is more data recently on the newer biologics. So these are antibodies made in the laboratory that attack certain elements of our immune system. So we've seen that in many of the non-IPF fibrotic lung diseases, the immune system mediates injury that may drive fibrosis. And on treating the inflammatory component, we're aiming to either prevent further progression or improve in some cases. And the likelihood of the response to immunosuppression will depend on a variety of parameters, including the pattern, the underlying ILD disease, and whether an associated cause can be eliminated. We know that immunosuppression is harmful instead in idiopathic pulmonary fibrosis. This was shown by the PANTHER trial, showing that the combination of steroids and azathioprine and an antioxidant led to increased number of deaths and hospitalizations because of chest infections. And we'll hear from Felix Chua about the effectiveness in slowing down the disease progression of antifibrotic agents. However, in the other non-IPF ILDs, as I mentioned, there is varying degrees of the likelihood of response to immunosuppression. This depends on many factors, but one of these is the underlying pattern that we often see on CT. So when the pattern is very inflammatory, as you can see up here in the highest CT slice, where you have an example of widespread consolidation, the white areas, we think this is organizing pneumonia, very high chance of responding. There are patterns that we call NSIP as an example. There are others, but this is an example where inflammation and fibrosis coexist, and other cases where it's mainly fibrotic pattern. And of course, the likelihood of response to immunosuppression increases as the proportion of inflammation in the lungs increases as well. I'm just going to touch on just a few selected clinical trials and studies because we don't have the time to go through all of them. Scleroderma, which is an autoimmune disease that affects the skin, thickening, but also internal organs, and very commonly the lung, causing lung fibrosis, is one of the diseases where immunosuppressants have been most studied. And as an example, the Scleroderma Lung Study 2 compared cyclophosphamide against mycophenolate. You can see here on the y-axis, FVC, that's forced vital capacity, and it's the parameter among lung function parameters that is best at looking at follow-up over time. And you can see that over the space of 24 months, there has been an improvement in the FVC in both treatment arms, mycophenolate and cyclophosphamide. Both groups also improved their symptoms of breathlessness and skin thickening, but mycophenolate was much better tolerated, less toxic, and therefore now it is one of the drugs, for example, that is most commonly used in scleroderma lung. There have been a number of retrospective studies which are not as reliable as a proper placebo or randomized controlled trial, but can still provide information, looking across the connective tissue diseases, again at mycophenolate. Here you've got FVC trends over time. The red arrow shows the start of the mycophenolate. Down here you have gas transfer, or DLCO, another key measure that we look at worsening or improvement over time. And you can see that with the introduction of the mycophenolate, there is a reversal of the downward trend. These are, of course, average values. And similar findings have been seen for mycophenolate or azathioprine in hypersensitivity pneumonitis, the lung disease that is associated with inhalation, for example, of modes and bird antigens. And here you can see, especially with regards to the DLCO, that compared to a downward trend before the introduction of the immunosuppressants, there is, on average, a reversal of that trend. And of course, this average will include patients that continue to progress despite immunosuppression and those that instead respond quite significantly. And in this review by Marlies Wijnspek and Vincent Coutin, and I'm not going to go over it in any detail, but you can see that across the different types of ILD, apart from IPF, where you would go straight to anti-fibrotic agents, because we've shown that immunosuppression is not only not effective, but potentially damaging, in all the others, we would consider immunosuppression as a first treatment, considering steroids, and then a combination or a selection of other immunosuppressive agents. And we may hear more from Felix Chua on the antifibrotic agents, but we now know with recent trials that if patients continue to progress despite immunosuppression, antifibrotic agents are effective in reducing the rate of progression. They're not yet available to prescribe in the UK, but should be at some point in the new year. And so we can think in general about treatment strategies for non-IPF ILD as at the beginning, when we first see the patient, the first decision we need to make is this a mild ILD with a low risk of progression, in which case we might decide to monitor, or is this a high risk of progression, even if early on, in which case we will consider treatment together with the patient. We will consider immunosuppression if more extensive. And these questions are what we need to answer with future trials. Should we be introducing antifibrotics early on in certain patients? Should we combine immunosuppressants in certain patients? And then if patients continue to progress despite immunomodulation, whether we can consider the addition of antifibrotic treatment or switch to antifibrotic. And these are all questions for the future. So in conclusion, we are seeing a lot of new data in patients with ILD, not only IPF, but also non-IPF ILDs. We have a number of drugs for different ILD entities, and we'll need to have trials about combinations of treatments. And one of the main challenges for the future is going to be how to tailor these various options to an individual patient so that we get the best effect, but also minimize side effects. Thank you very much.
Thank you, Elizabeth. That was a fantastic, beautifully timed overview. I appreciate it's an incredibly complex area, but I do stress to patients you can put questions in the Q&A, and we have time at the end of all 4 talks to try and answer those questions. It's an exciting area in terms of increasing amount of treatment that we should be able to have. Right, without further ado, I will introduce Dr. Felix Chua, who's one of our colleagues again from the Royal Brompton Hospital. He's going to speak on the treatment of idiopathic pulmonary fibrosis and potentially other conditions with anti-fibrotic therapy. And Felix, just to say, I do notice on our timings, you do have a couple of extra minutes afterwards. So I know that there have been some pre-questions which you might take the chance to answer as well. Brilliant. Thank you.
Thank you very much, Alex. Good morning, everyone. The biggest of thanks to everyone who's attending, the people in the audience, because you're both patients and carers, and you're the people we look after. So thank you for coming on today, and a big thanks to Peter George, Sujal Desai, and to Alex for sharing. This is a very important event. And I'm so glad that Elizabeth said there'll be questions for the future rather than questions for Felix, because I'll try and answer as many as I can, but I'm sure some of them will have to come back to another time. But there are broad messages to give you. Elizabeth did a great job in covering the plethora of medications we can use. I'm focusing on two, namely the two anti-fibrotic drugs for idiopathic pulmonary fibrosis. Up to this point, pirfenidone and nintedanib are the only two drugs to transition successfully from research to the clinical arena for daily use. And more importantly, they're the only two drugs shown to change the course of the disease in people who take them for long enough without major problems. They can adhere and comply with the treatment. They have a very good chance of having the disease slowed down. Disease slowing essentially is a change of disease behavior. And that's why this is so important, because if we look back at the history of antifibrotic drugs, from the very first small study in 1991 of steroid added to azathioprine, and for the 2 decades after that, all of these drugs simply didn't work. There is then a remarkable 5-year window between 2009 and 2014, when there are 4, or in fact 5 phase 3 studies concentrating on 2 drugs, pirfenidone and nintedanib, that worked. These drugs were shown to be much better than placebo. And I'm going to show you some of the data. A lot of you will know the results already, and some of you be on the treatment. So you've read around these 2 drugs. But in essence, pirfenidone was the first on the scene. The first phase 3 study was published by the Japanese in 2009. And then the global studies, capacity 1 and 2 in 2011, followed 3 years later by the latest phase 3 study, Ascend. This was the definitive phase 3 study. In the same year, Impulses released the data on nintedanib as the other anti-fibrotic drug. So all of those are concentrated in this time period. The axis at the bottom is time, the axis at the top are the studies. So what are these drugs? Nintedanib is a tyrosine kinase inhibitor. You may have heard about TKIs in other parts of medicine. For example, in cancer therapy, TKIs are important anti-cancer drugs. TKIs target a number of pathways in cells. So they are broad-ranging, but one of the important effects is their ability to retard scar tissue formation. And for nintedanib, it works by inhibiting different molecular pathways that conspire to lead to the formation or development or accumulation of fibrotic tissue in the lungs. Pirfenidone is not a TKI, but it's a low molecular weight compound, also known as a pyridone, and it has, similar to nintedanib, a number of broad-ranging biological actions. It is an anti-inflammatory, it has been shown to be an antioxidant, and importantly, it's an anti-fibrotic too. In animal experiments, pirfenidone has been shown to retard or inhibit the formation of collagen and other components of scar tissue, but importantly also to inhibit the cells, the fibroblasts that make them. There are, if you have read the papers describing the data, the phase 3 data for both drugs, you see that there's a lot of data to go through. But this is the key graph. This is the key finding for nintedanib from Impulses. The dark blue bar is the treatment arm, nintedanib patients who took 150 milligrams twice a day for 52 weeks. The light blue bar are those on placebo. And you can see this axis here is the adjusted change, the fall in lung function over the course of the study, which was 52 weeks, over the course of a year. It's important to note that the horizontal bar at the top is 0, meaning every patient actually dropped the lung function to some extent. Some of them were stable, but a lot of them dropped the lung function. So the first message is that nintedanib doesn't completely and durably stop the disease process, but it can slow it down. It cannot take away the scar tissue that's present. That's the biological reason for this. But let's come back to the data. The patients who took nintedanib, on average, as a group, lost about half as much lung volume or the vital capacity compared to those who took placebo. This is about a doubling or halving, if you like. The next slide shows data from the ASCEND study, which is the pirfenidone versus placebo study, and a slightly different expression of the data, but the message is very similar. If we just concentrate on the first pair of bars here, this histogram shows, again, patients on pirfenidone in the darker bar, patients on placebo in the lighter blue bar. Again, you can immediately see there's a contrast in the height of the bars. In essence, now looking at patients who either lost more than 10% of their lung function or death, pirfenidone treatment is associated with fewer numbers of patients who either suffered lung function decline or died. So again, this is sort of a halving of effect, if you like, a biological effect or an outcome. The pair of the graph on the right, the histogram here with the two bars, again, patients in the dark blue and placebo patients in the light blue, is slightly misleading. Pay no attention to this bit at the top that says 132% increase, because at first glance, some people might think that's an increase in lung function. It's not that at all. It simply shows, but it is an important message that for some patients on treatment, they're able to have no decline. They do not lose lung function, or certainly in the study, over the course of the study over a year, they did not lose their lung function. This allows the drug to be described rightly as a compound that can stabilize the condition in some people, the disease. I have to say, in the real world, this is true too for nintedanib. So it's not just an effect of the pirfenidone. Both drugs can stabilize lung disease as measured by lung function over time. In England, the eligibility criteria for anti-fibrotic treatment for patients with IPF are quite clear. There are two criteria. Number one is they need to meet an MDT. They need to have an MDT diagnosis of IPF. At the Brompton, this happens every Wednesday afternoon. We discuss a huge number of cases, not just IPF, but a variety of lung conditions. But one of the main objectives is to get an MDT diagnosis for patients that we think have IPF so that they can access treatment quickly. The second criterion is that the forced vital capacity as a parameter for sizing up their lung volume must have fallen to between 50 to 80% of predicted. During this time, and from last year onwards, we've made a modification. We are happy to accept, and this is true for every prescribing center in England, not just the Brompton or Guy's and St. Thomas's, that physicians prescribing these drugs are happy to accept a lung function done within the last 12 months and if done at the local hospital. They don't have to come up to the prescribing center to have it done. We should also remember two important other bits of information about these drugs. And this is always discussed with the patient at the outset. Number one, these drugs do not and are not expected to reverse fibrosis. So the scar tissue that's present in the lungs will stay present. What the drugs do is, over the course of time, in patients who can adhere and comply with the treatment without too many side effects, they have a very good chance of having the drugs slow down their disease. Secondly, these drugs are not designed to reduce symptoms. They are not they're not symptom targeting drugs. So in a lot of people, they don't actually experience a reduction in the breathlessness or cough. But there are quite a few patients who tell us that once they've started treatment, even if it doesn't happen that quickly, it does happen over a number of months, they seem to experience less breathlessness. And I've just seen a patient last week who told me that his cough improved within 2 months of starting an antifibrotic. So there are those patients who reported a change in the symptoms, but by no means in a large number of patients. I think this is important. Side effects are very important. If you go to the OFEV website, this is what you see. I'll show you a similar table from the Esbriet or Pirfenidone website in a minute. But for OFEV, what they've done is they put liver problems at the very top. Liver problems are uncommon. They really are. I think what's happened with nintedanib is there have been a few patients who've developed liver problems, quite significant liver dysfunction. So they're shown the light on hepatotoxicity or liver toxicity as a potential consequence of the drug. So it's up there. But in fact, it's diarrhea, nausea, and vomiting that's common. It's more common. And that's true too for pirfenidone. In fact, liver problems don't appear at all in this table. If we go to the trial, the actual impulsive study, nintedanib was associated with diarrhea and nausea in up to 2/3, nearly 2/3 of patients in the trial on the drug. In the placebo arm, it was about 1 in 5, a bit less common or less frequent for nausea, but still quite substantial, 1 in 4 patients. And loss of weight is important too down here. And this is pirfenidone. I've shown you the data on side effects, which is slightly differently expressed. I think this is important because if you look at the top, nearly every single patient reported 1 or more side effects. Some of them were very minor, very, very mild, but they had to be recorded. The serious side effects were more common, interestingly, in the placebo group, 1 in 4. But if you drill down on the information, this was why. That respiratory failure and chest infections were included within the serious adverse effects, but actually, for a lot of people, they were related to intrinsic worsening of the lung condition and not because of the placebo, which is why in the placebo arm, fewer people had stopped the trial because of side effects and more, as we would expect, receiving pirfenidone. Alex telling me I've got no more time. Okay. Can I show 2 more graphs? Because I think there are some questions about this. I've put it in the last minute. There are people who want to know about mortality, extension of life. So this is a real patient who is still with the Brompton lung function tested not long ago, earlier this year. She started on compassionate use nintedanib in 2015. She had very large lungs to start with. She was born with very large lungs, but this is where she started. There's a short period, there's a couple of years when things are stable, it then starts to slide, but I think nintedanib is putting the brakes on, because at this point, she's stable again. But this is one of the reasons why we can't just focus on FVC, because if you look at the green line, which is gas transfer, it stabilizes, then starts to slip, and although it's stable here, it's around 20% predicted, so she's on oxygen, et cetera, but she's been on treatment for 6 years. She's clearly not in the 3 to 5 year mortality group that everyone reads because Google doesn't police these data. The second patient, to be fair, is somebody who took pirfenidone. Sadly, he demised last year, but he was on treatment for 8 years. Across 8 years, he dropped his lung function from 3.5 liters to 2.9 liters, 640 mils over 8 years, an average of 80 mils per year. But of course, he didn't lose 80 mils every year, most of that towards the last few years. His lung function also included gas transfer, which plummeted. And by the time he had a lung function and FVC of 87%, in fact, he was very symptomatic because his gas transfer was so low. He was accepted for transplant 2019, at which point he was already very advanced in his disease and sadly demised last year after an infection. But these are just 2 cases to show you that treatment can be taken, can be accepted, can be tolerated for quite a few years and can work.
Thank you very much indeed. That's absolutely brilliant. Thank you for covering a big, big topic in a short period of time. I'll move quickly now on to Dr. Maria Kokosi. And lots of you in the chat have been putting in questions about rarer lung diseases. And we at Brompton and St Thomas's look in detail at the rarer lung diseases as well. They're important to look after and diagnose, as well as the slightly more common ones of other pulmonary fibrosis we've discussed. Thank you, Maria.
Thank you, Alex. Thank you for the presentation. So I am a consultant in the interstitial lung disease units, both at the Royal Brompton Hospital and St Thomas's. And one of my main areas of interest are the rare cystic lung diseases. Okay. So there is a variety of disorders which manifest with lung cysts, and I will show you in a minute how lung cysts look really. But I will focus just on 3 of them, and this is lymphangioliomyomatosis, Langerhans histiocytosis, and Birt-Hogg-Dubé syndrome. These are the pictures of 6 different patients with 6 different diagnoses. The cysts are these black holes in the lungs. I'm sure you can see them. They're of different size, distribution, and shape. And actually, these characteristics of the cysts can be quite helpful in the diagnosis. So this is a patient with LAM, this is a patient with Langerhans that we will discuss, and another patient with Birt-Hogg-Dubé. The symptoms include shortness of breath on exertion. The patients can cough, they can report wheezing. Pneumothorax, collapsed lung, is very frequent in these diseases, often can be the first manifestation, the presenting symptom of the patient, and some of them can develop pleural effusions, which is actually fluid which accumulates in the chest cavity. I will start with LAM, lymphangioliomyomatosis, a rare disease with multiple cysts. It's an almost exclusive disease of women. It is characterized by proliferation of abnormal smooth muscle-like cells. They're called LAM cells, and those accumulate around the airways, the blood vessels, and the lymph vessels, and that's how the name of the disease actually originates. The main effects of LAM are in the lung, with the cystic changes that can progress and worsen with time, but approximately half of the patients have benign tumors in the kidneys, the so-called angiomyolipomas. Lymph nodes can be enlarged, but they do not really cause major problems. LAM can occur on its own, and it is called sporadic. We don't know the cause, but we know it is not inheritable, but it can also be inheritable in patients who have tuberous sclerosis complex. As mentioned, the CT is characteristic, but there are some other features that are helpful in the diagnosis, like the presence of angiomyolipomas, the benign kidney tumors, the pleural effusions, which are very characteristic. We call them chylous effusions. They have a very characteristic milky appearance. The findings of the tuberous sclerosis complex, and then VEGF-D in the blood, which I'm going to explain in the next slide. VEGF-D, vascular endothelial growth factor D, is a growth factor which is produced by LAM cells and promotes their migration and proliferation. We can measure VEGF-D in the blood, and it is a test not widely available, but it is in our center. LAM is currently considered as a low-grade metastasizing neoplasm. And here is the role of the VEGF-D in the blood, which can distinguish LAM from other diseases. Just briefly on treatment, this is a large clinical trial from 2011. The drug is the sirolimus. I will not go into detail, but just to say that it showed that stabilized lung function in patients with LAM. It reduced the levels of VEGF-D in the blood, which means it reduced disease activity. It was associated with improvement in the patient's symptoms and improvement in quality of life. Pulmonary Langerhans histiocytosis is characterized by infiltration of the lungs and other organs by the typical Langerhans cells derived by the bone marrow. It presents predominantly in young smokers and can be either male or female. It is associated with various gene mutations, but it is not actually an inheritable disease. And there is a long debate as to whether it is an autoimmune disease or actually a cancer. Apart from the lung involvement, Langerhans can involve other organs and more often the bones. So it is important that the patients are assessed for any extra pulmonary involvement, and for that purpose we use the PET scan along with other investigations, of course. Treatment depends a lot on the organ that is involved. If it is exclusively pulmonary disease, the most important parameter is smoking cessation. If we have other organ involvement, single or multiple, then we would consider systemic treatment. Many of you will be familiar with methotrexate and azathioprine immunosuppressive drugs that can be used in Langerhans, but the majority of the drugs we use are actually chemotherapeutic agents. And briefly about Birt-Hogg-Dubé, which is a very rare syndrome. It is inheritable. It runs in the family and is characterized by lung cysts, skin lesions, and kidney cancer. The majority of the patients, 85%, will present with lung cysts, and very often the first symptom is pneumothorax collapsed lung in 2/3 of the patients. And it is interesting that the pneumothorax will reoccur in the majority of the patients. These are the skin lesions, the fibrofolliculomas, quite characteristic of the disease, and 1 in 4 patients will develop kidney cancer at some stage, especially after the age of 60. I will just go through these quickly. With regards to the follow-up, apart from the lung function test, in those patients, annual kidney imaging is very important for early detection of kidney cancer. There are no available treatments, but prognosis is very good, especially when it comes to lung disease, which does not seem to progress over time. And I will use this opportunity to present and introduce our rare cystic lung disease collaborative network. It is a new, relatively new network recognized by NHS England a couple of years ago. Collaboration between our hospital, who has the leading role, and Queen's Medical Centre in Nottingham, which is the National Centre for Lung. We have a joint MDT, and we provide multi-specialty assessment and various diagnostic modalities, various external collaborations. I will try to speed up because I see Alex on my screen. And just to present our service, I run this service with a weekly specialist clinic at the Brompton, a smaller satellite clinic at Guy's and St. Thomas's, and we have a monthly MDT where we discuss exclusively patients with rare lung diseases. These are pictures from our first patient day pre-COVID. Hopefully we will have the next one soon, and thank you very much.
Thank you very much, Maria. And I think that final slide sums it up beautiful. We care about the rare. That's a beautiful thing to say. While we set up with Felix, obviously there will be opportunities for questions at the end. Just to stress, obviously Maria did talk about cancers in her condition. This is not associated, cancers are generally not associated, and is not something you should be worried about in general other conditions, just in case that comes up in the chat. So we're now just on to Nonni Reed, who's hopefully with us and dialed in. She is. She's a consultant in respiratory and transplant medicine. Thank you, Nonni.
Hello, good afternoon, just about. Very happy to be here, so thanks for having me. I'm a lung transplant physician. I work at Harefield Hospital, so I'm going to finish the morning session for today and give you a very brief overview of lung transplantation, and also been asked to talk about ECMO and sort of super urgent listing, which I'll talk about at the end. So 10 minutes isn't long, so bear with me. Okay, so lung transplantation, what are we trying to do? We're trying to offer the chance of improving your quality of life, making you actually feel better, getting rid of the breathlessness, the cough, other respiratory symptoms that you may have, and obviously increase your length of life as well. There's approximately 200 to 250, I've said lung transplant here, it's cardiothoracic transplants, so heart and lung transplants annually in the UK. We do between 150 and 200 lung transplants nationally in the UK. So not many if you think about that as a factor of the whole country, and certainly not many if you put that into the context of number of kidney transplants, which is more like 8 to 10,000 annually within the UK. Okay, this is a graph looking at international data. I think it's really important for patients coming into transplant to understand that whilst transplantation is designed to offer you improvement in your symptoms and your length of life, it's not a cure and it's not a complete panacea. These numbers at the bottom don't show very well on this background, unfortunately, but just where my mouse is here, that's 5 years post-transplant. So we tend to quote patients statistically a 50% chance of being alive 5 years after a transplant. That is a statistic, and we have patients who do exceptionally well, and I've certainly got patients who were transplanted in the very early eras of transplantation who are alive and well 30 years after a lung transplant, and there are patients who do significantly worse than that and sadly succumb to problems related to either the surgery or immunosuppression and infection at a much earlier stage. So it's very difficult to say to a specific patient what your likely outcome from transplant is, but it's something that will offer you more time and improvement in your symptoms. But timing is crucial because obviously we want to make sure you have as much good quality time as is possible. Now the white line here is the IPF line, and that's the hardest one to see. Longer term outcomes in ILD compared to other indications for transplant are slightly worse than the other disease groups, and that is predominantly due to some of the associated comorbidities that go with ILD. Okay, so this data, I put this in literally yesterday because this document was published yesterday. All of the data relating to transplantation in the UK is in the public domain. It's published via the NHSBT website. As I say, this document was published yesterday afternoon, so it's hot off the press. This gives you numbers of lung transplants and organ donors over the past 10 years or so. And the line at the top is the number of patients waiting on the list. You can see clearly 2020, 2021, everything went down, and that's as a direct result of the COVID pandemic. Unfortunately, clearly COVID being a lung disease, there were not many lungs available for transplant is part of it, but also patients requiring lung transplantation are significantly at risk of COVID, and we've tried to keep people away from hospitals as much as possible, but it's definitely had a direct impact on our ability to transplant patients. So as you can see, numbers are quite low, and it's a fairly niche operation in many ways. What happens to patients once they're on the transplant list? So this is data over time. The dark blue at the bottom is patients get transplanted. Light blue is waiting, and then sadly some patients will die or have to be removed from the list. So once your patients who've been on the list for about 6 months, usually about a quarter of those patients have already been transplanted. But this gives you some idea about waiting times. And how many transplants are we doing altogether? Now, this graph unfortunately shows that numbers have gone down very significantly in the last year, and again that's due to COVID. The graphs change in the 2018 era because we introduced the concept of urgent and super urgent listing. These are concepts that have been in place for cardiac transplantation and liver transplantation for some time. I'll talk about that a bit more at the end, but the idea being that patients who are deteriorating rapidly have prioritization nationally for organ allocation if they meet certain very well-defined criteria. This also is from the NHSBT document and looks at the centres that are doing transplant in the UK. There are 5 adult centres. Each centre transplants different groups of patients, and we all have different characteristics in who we transplant in many ways. Historically, Harefield, I think, has been known as a team that have not transplanted the same proportion of patients with ILD, and that's been predominantly because we have, for a variety of reasons, become a sort of cystic fibrosis centre predominantly over many years. The CF patients have thankfully had their drug therapy that really works in the form of CFTR drugs, and a lot of the CF patients are coming off our waiting lists, which means that we are now doing significantly more interstitial lung disease transplants. I looked at our data yesterday, and in the last 12 months, as of from yesterday, 48.9% of our transplants were in interstitial lung disease. So that's significantly changing, which I hope is reassuring to all of you in the audience. Also, something that you should be looking at as a patient, as I say, it's in the public domain, is long-term survival in patients post-transplant. Now, this is survival up here, and these are the 5 centres. So you can look both at short-term, 90-day, 1 year, and then 5-year, 10-year survival across the centres to decide and guide you in which centre you would like to be referred to. And as I understand it, there is a large amount of patient choice in that. So I would advise you to look at these documents to make your decisions if you are referred for transplant. And what happens when you are referred for transplant? Well, there's a national document that all referring centres will fill in. It states the centres on the front. Obviously, there's some demographic details. Then there's quite a lot of detail. Now, the referrals are very detailed, and that allows us to make good decisions at the point of referral. Obviously, we want to know what's the matter with you and what your lung disease is. We want to know about background history of smoking, in particular, any alcohol or drug issues that may impact ability to take medication post-transplant. We're unable to accept patients who are currently actively smoking or even using nicotine replacement therapy, and that's a national rule. We need to know what bugs you've got and have some understanding about whether or not we will be able to treat your infection post-transplant. In the post-transplant period, you would need to take strong immunosuppressant drugs. Some of them very similar to the ones that you may have taken pre-transplant for your interstitial lung disease, but significantly more drugs and stronger, and therefore infection is a real problem. We need to know how much oxygen you are using, and that gives us some understanding of how bad your disease is and how it's progressed. And your exercise capacity. One of the things about transplantation is that fitness for surgery is hugely important, and if patients sadly have become very frail or unfit as a result of their lung disease, then it's often not possible to get you through a transplant operation. So one of the best pieces of advice, both in terms of managing your breathlessness, but also in terms of keeping yourself fit for as long as possible, is to keep exercising. And also we need to understand how your disease is progressing in order to understand where the time for transplant might fit in for your specific case. There's a lot about past medical history and comorbidities, medication, and any other issues. Okay, so who do we select for transplant? Generally, it's anybody with very advanced lung disease that's progressing despite treatment and who has severe symptoms. Again, all of these documents are in the public domain via NHSBT. IPF, one of the main problems we have with patients with IPF is that it causes shrinkage of the lung, which in itself doesn't initially strike people as that much of a problem. However, what happens is that as the lung shrinks, the chest wall is also brought in with it, which means at the time of transplant, when we try and put enough lung in for a person of that size, it can be very difficult to either fit the lung in or close the chest afterwards. So we often have conversations about chest size and capacity, and it becomes a very technical issue, which our surgical team will make a decision about. So issues specifically in ILD is when to refer, and we have obviously very frequent conversations with our ILD colleagues. We have regular MDTs where we talk about these things and make sure we're trying to refer patients at the right and appropriate time. We have to assess the other comorbidities, particularly heart disease, kidney disease, liver disease, very carefully. Patients with connective tissue disease often have a number of additional issues in the form of reflux or skin issues, which contribute to our decision making. And as always, because this is a very surgical specialty, we have to make decisions about whether or not the lungs can be removed safely. And again, that comes down to the surgical team and their view on that once we've reviewed all of your imaging. So following referral, we look at all of our referrals, which I've shown you are fairly comprehensive in our weekly MDT. If the physician team feel that it's appropriate to see you in clinic, we'll see you in clinic, hopefully within 6 weeks, and then admit you for, it was a 4-day assessment, it's actually been reduced to a 2-day assessment within 2 months, where we do a sort of top to tail MOT and try and ascertain what problems there may be and whether or not transplant is the right option for you. There's also a lot of information exchange where we tell you the good, the bad and the ugly about transplantation to see whether actually it's a life that you wish to commit to, because it is a lifetime decision, and you swap the ILD doctors for the transplant doctors. We review your case at the full transplant MDT with our surgical colleagues and make a decision at the end of that assessment week. Once you're on the waiting list, very important, the exercise, I cannot overstate that. Got to try and stay fit. We've noticed a number of patients on pirfenidone and nintedanib can lose weight because they can get quite significant nausea. Sometimes we've resorted to having to put a PEG feeding tube in order to maintain nutrition and maintain robustness and help with your physical fitness. Obviously, control diabetes, comorbid disease. And we are very careful about any other intervention that may happen. Usually we keep very close connections with your referring doctors and discuss these things at length when necessary. Patients always ask, how long am I going to wait for a lung transplant? It's very variable. This again is from the document that I've showed you before. It depends very much on your blood group and your size, and if you're a small blood group O, then you're likely to wait longer than if you're a tall blood group A. Those things are what they are, so you can't change them. What happens, usually you'll be called in for transplant and hopefully that will go ahead. There are different surgical approaches. Hi Alex, I can see you're there. The thoracotomy incision is the biggest incision, but it heals to leave a scar like this, which is usually not too obvious unless you're on the beach. And ideally we'll get you through theatre and out and discharged within 2 to 3 weeks if everything goes well. It is more complicated than that, and that's obviously a very brief overview, but if things go well, then patients are often discharged in that time frame. So urgent listing, I'll just finish on this point. National urgent and super urgent listing were introduced in 2018. It is very difficult to get onto an urgent list, and there are very strict criteria. You need to be on very high levels of oxygen with very low levels of blood oxygen, but that allows you to be prioritised nationally. Super urgent listing requires you to be on something called extracorporeal life support, or ECMO. This requires you to be in hospital in the intensive care unit, and these patients are very, very sick. As a reminder, the numbers of patients, so blue here is urgent and grey here is super urgent. So this is in the last year, which admittedly was a low level year for transplantation, but clearly these numbers are absolutely tiny. So it's not something we are able to offer to many, many patients. And who are we able to offer ECMO to? Patients need to be active, and we go back to the exercise point here. Reasonable size and blood group, which means that we're going to be able to match you with an organ in a reasonable time frame, and physically strong with no obvious nasty infections that are causing the problems. There are 3 types of extracorporeal life support. Essentially, it requires tubes to be inserted, blood is removed, oxygen is put in, blood is put back in. Oxygenated blood goes back into the patient. It requires a vast amount of kit, so it's really not for the faint-hearted. And the other thing to understand from a patient's perspective is that patients need to be awake when they're on these devices in order that we can continue to push the you must physically move and do exercise so you stay strong enough for transplant. It's a very difficult place to be on ECMO as a bridge to transplant, particularly because you need to be awake, and particularly because once you're on ECMO, there's really only 2 ways out of the hospital, and only one of them involves transplant. This is one of the reasons why there's so small numbers, but we have had success in patients with interstitial lung disease who have developed severe acute respiratory failure, and we have good outcomes if we keep patients awake. But as you can see, it's a very niche route to transplantation, and we would much rather transplant you before whilst you were fitter than this. So that's the end of my presentation. I think I've overrun a bit, so apologies for that, but very happy to take questions if there are any. Thank you.
Thank you very much, Nonni. That was incredibly swift overview of a really difficult area. We'll get rid of that final slide here, and then we'll move on to the open discussion. So if all of our 4 speakers can be ready to unmute and discuss, I'm going to go with the questions in the Q&A. Thank you very much for putting in all of your questions, everybody. There are some various broad themes, which I'm going to direct at our various speakers to try and answer as many of your questions as possible. I'm actually going to start with Elizabeth, first of all. There have been a lot of questions of people with different inflammatory interstitial lung diseases who are asking about the combination of antifibrotics. I wonder if you could give us a little hint of what might be coming in the future and what's already here.
Sure. So, of course, yes, that is a very topical series of questions. And we know from the INBUILD trial that antifibrotic treatments, and in particular nintedanib in this trial, added on or introduced in patients that had progressed despite appropriate treatment for their condition, which would have included in many cases immunosuppression, was effective in slowing down disease progression. So I think what we will be able to do is to consider anti-fibrotic treatments in those patients that are not either improved or stabilized by immunosuppression. Now, of course, because any drug, including, as we've seen from Felix's talk, nintedanib, is associated with side effects, which in some cases can be considerable, we wouldn't necessarily be choosing antifibrotics for every patient. And as I said at the end of my talk, it is in the individual patient consideration of what is the best combination. So it will be possible to start on antifibrotics in patients who are progressing or have very extensive lung fibrosis, but in patients who are stable on their current treatment, there wouldn't be an indication to go for that.
Thank you, that's extremely helpful. There have been questions from people who've got different connective tissue disease, sarcoid, and chronic hypersensitive pneumonitis. That covers quite a lot of those. That's really, really helpful. Felix, there are questions regarding the treatment with antifibrotics and idiopathic pulmonary fibrosis. Questions as to why it is chosen that we choose their lung capacity rather than their ability of the lungs to take up oxygen. Why are there restrictions in the UK?
Thank you very much, Alex. And to the questioner, I think the simple reason that we choose FVC is it is a cleaner measurement. It is probably less susceptible to noise in the system. It's more difficult to do a gas transfer factor because it's a triphasic test. You have to breathe the gas and hold your breath. And if you've got lungs with smaller volume because of fibrosis, it's actually very hard to hold your breath. And that whole breath hold has to be 4 to 6 seconds for the gas to then distribute and then you blow out again. So it's a bit messier. I think it's a difficulty of performance issue. FVC, on the other hand, isn't that easy to do either, but it requires to breathe in, then blow as hard as you can, for as long as you can, and you do it as a best of 3. So I think on balance, FVC is just a bit cleaner, and that's the one that the FDA has decided to use as the parameter for trial output. That's not to say that in the future we wouldn't do gas transfer. Certainly in the clinical practice in every center for transplant, for you guys, for us, for everyone else, we keep an eye on TLCO. As I showed for those 2 examples of patients, even before the volume dropped significantly for people with large lungs, they were born with large lungs, it's the gas transfer that's dropped significantly to the point where it's not sufficient to support life without additional oxygen or quality of life without additional oxygen. So it's very important. It is messier to measure.
Thank you very much.
The other question is about thresholds, I think, wasn't it?
Yes, that's right.
Yeah, I think it's an open secret that the use of 50 to 80%, that range is partly economics based, and the modeling is economics based because it's it's judged on quality of life years, quality adjusted life years, and that's the modeling that a lot of countries use, certainly the one that NICE uses. So economics comes into it. We're all fighting, as you know, to try and abolish that 80% threshold at the top, or maybe get it moved upwards, and that's an ongoing challenge. But we wait and see. And NICE hasn't said anything about moving the 80%, so we just have to wait and see.
Thank you very much indeed. A question for anybody that would like to answer from the panel. The question of the COVID vaccine and immunosuppression. What is the efficacy of the COVID vaccine and immunosuppression and the timing of things. I think the first important thing that we'll all say is it's very important for everybody with interstitial lung disease to have the COVID vaccine and the booster where appropriate. Would anybody like to take that from the panel in terms of efficacy?
I'm happy to do that as my topic was immunosuppression. So and then welcome for the others to also comment. So basically, it is a very good question because, of course, immunosuppression, especially if it is above a certain level. So if you're on either combined immunosuppression, such as in a transplant situation, or even on high doses of our sort of single agent immunosuppression, such as mycophenolate and steroids, for example, there are studies that have shown that the likelihood of responding to the vaccine is lower. Now, the majority of studies have just looked at immunoglobulin responses to COVID vaccine. There are also cellular responses to COVID vaccines, and the studies on that are much less. So we don't know whether, even if you don't have a proper antibody response, your cellular response might still be reasonable. However, the fact that immunosuppression is associated with a lower likelihood of a good response to the vaccine is the basis of the recommendations for the third dose 8 weeks after the second, and then a further dose after 6 months. Now, there has been some delay with that, but I would say that certainly one should get a third dose if you're on immunosuppression, because that has been shown to be more effective and to increase the proportion of patients that get an antibody response to the vaccine.
Brilliant. Thank you very much. Nonni, you've got your hand up to comment on that as well.
Hi, yes. So we've done some work specifically looking at antibody and T-cell responses to vaccination post-transplant. Transplant patients usually take a combination of medications that include mycophenolate and prednisolone, so drugs that are similar to patients that drugs that you would take for IPF. And we've shown, certainly in the transplant population who admittedly have higher levels of immunosuppression, that both T-cell and antibody responses after 2 doses of vaccine are really quite subdued. We've had some patients coming through who've had their third dose, and the antibody responses have also been quite subdued. We know from the renal transplant literature that mycophenolate in particular is associated with this dampened down response. There is a huge requirement for more work in this, but certainly with our transplant patients and with anybody who's taking immunosuppression, I think we need to still advocate shielding and really trying to be careful in the face of COVID, because it's not gone away, and we need to understand more about this disease and how it's affected by the drugs that patients need to take.
Thanks, Nonni. And whilst we're on COVID, there's a specific question which I think is a really good one. Will patients with damaged lungs that are permanently damaged from COVID be considered for lung transplantation?
Short answer is yes.
Fantastic. Yeah. Thank you very much indeed. That's very useful. There's also just a question that's come up in the chat about the which 2 or 3 people have asked about the BBC programme mentioning the patient's own blood cells could treat lung scarring. That is something that I'm involved at Guy's and St Thomas's. It's only been 5 patients in a very, very early study, so I'm afraid it's not yet available for other patients, but it's something to watch this space on, and we hope it would evolve. Just a couple of other generic questions to finish with, which is a common question that I get. Again, maybe Maria, you might like to take this one. It's about low oxygen levels, because there's a question that does the low oxygen levels themselves damage lungs in interstitial lung disease, or how do we look after that?
Well, it is So low oxygen and supplementary oxygen in interstitial lung diseases has two roles. One is more regarding quality of life, and this is a large clinical trial that Elizabeth supervised, showed that it results in improvement in quality of life, but it also has a role, especially overnight oxygen, in prevention of development of pulmonary hypertension.
That's extremely helpful. Thank you very much indeed. Right, I am conscious that it's 12:30, which is the end of our session, and it's been a long morning. I would appreciate there are some unanswered questions in the chat. Myself and my colleagues and the colleagues from this morning will try and answer as many of those individually where we possibly can. I'd like to thank the audience for participating and our speakers, and we look forward to seeing you in the afternoon session in a little while. Thank you.
Just on the questions, Alex, can you hear me?
Yeah.
I've been working quite hard at questions because I was speaking in the first session.
Thank you so much, Ethel.
I find when I answer and I don't tick private, the question vanishes, but I don't see the answer appearing on chat anywhere. So I don't know what's going on there, but I've said detailed answers. Which
that's fine. Ethel, we're still broadcasting, so we'll talk in the chat. Thank you very much indeed.
I want people to know that their questions have been answered, and if the question vanishes but you're not seeing the answer, just for the team to tell people who may seem to have had their questions dismissed what is happening.
Fantastic. We'll try and that's very, very helpful, Ethel. We'll try and get through those as much as we possibly can in the next half an hour before the next session. Thank you.